changes in lung anatomy. The body region we are treating is the right lung and mediastinum. We are using a VMAT rapid arc procedure. And this particular patient had recent SBRT to the right lung, so we want to make sure we minimize dose. And of course, we're using the predicted mode. So the clinical information in supporting the rationale for replanning based on results from Adaptivo in vivo dosimetry are as follows. The first one is the need to minimize dose wherever possible due to the previous SBRT within the current treatment region and overlapping volumes. This patient had significant fluid in the right lung during CT stimulation. And because of that, it affected the planning because this is the same CT study that was used for that treatment planning. Next slide is, our particular physician was concerned about the total dose to the lung, so he decided to go with BID fractionation due to that previous SBRT treatment and due to relatively large volume now being treated to a fairly high dose. The previous SBRT treatment was at 7 gray per fraction in 5 fractions to a total dose of 35 gray. The current prescription is for an additional 65.5 gray. So as you can see, the potential to exceed 100 gray in total dose is very real in this particular case. The area previously treated was considered an at-risk structure because we needed to make sure that we minimize the total dose to prevent necrosis in the patient's lung. Any changes in internal anatomy could potentially result in an overlap between the current and previously treated PTVs with unacceptable hotspots, increasing risk for tissue necrosis. This is a simple screen capture of the final prescription. The original prescription was BID to 1.25 gray per fraction for 38 fractions, so a total of 47.5 gray. This prescription amendment reflects the discontinuation of the initial course early and to modify the existing boost. The original prescription had the initial going to 50 gray with a 12.5 gray boost using the original CT study. You can see now it says SIM2. So there's a new CT study that is being used to do the boost planning. Now, for those of you that are familiar with the Adaptivo software, for each treatment plan for each patient, you get this bar that has these little squares. We refer to these commonly as the chiclets. So as you can see, for the first 6 weeks of treatment, everything looked fine. Green means above tolerance. So we were passing above our set threshold. And then all of a sudden here, we start to see yellow, and then on the end, which are true failures. The yellow is considered borderline tolerance, and the red is considered a true gamma failure. If you click on any one of these chiclets, you get the expanded view, which is the larger view that you're looking at now, which should match. So up on the top bar, this first yellow chiclet would represent this gamma failure here at 79.5. It was slightly below our threshold of 80.0. So you can see as time progressed, the gamma started getting worse with more failures and more borderline tolerance results. Now also, you see there is a vertical column that is gray. That is different from the columns that are not gray. For example, fraction 31 here is a daily result, and if I go to the end, it says average result. So every week, the Gamma software will take a composite image of your 5 daily images and then run a new Gamma on it using that average image to give you the average Gamma result. It also shows images of what your pixels look like in the Gamma analysis. So if the pixels show up as red, that means they're the hot areas, and the blue is the cold areas. In this particular case, for this particular beam on fraction 35, this is arc 4, you see all we see is red, meaning that the patient is getting more dose than predicted. And that is possibly due to the tumor regression and weight loss for this patient. Definitely a change in anatomy that needs to be taken into consideration. It also shows very nice profiles. The one on the left is in the x-axis, the one on the right is in the y-axis. For this particular beam, the red line is showing the predicted dose, and the green dashed line is showing the portal dose. And you can clearly see that the entire field is receiving more dose for that daily fractional treatment than you did in the predicted. Another view of this to show our dose tolerances as well, our gamma tolerances, is this view here. For that same particular arc, on the left, you see the percent gamma. So this is at 5%. And we're using a DTA, distance to agreement, of 3 millimeters. So the result is 57.71, which is below our failure threshold, and it shows up as red. The green, of course, is above threshold. The yellow is borderline threshold. And then the red would be failures. And it's pretty obvious. For example, if I use this very first one here, 17.73, that's with the dose constraint of 1% and a DTA of 1 millimeter. Almost all pixels will fail that. Oppositely, if I go to the far right-hand corner, a dose threshold of 10% and 10 millimeters, almost all of the gammas will pass. All of the pixels will pass that gamma. This is a very, very helpful view. It shows a trend analysis over time. So as you can see, for the 4 arcs, everything seemed to do fine for the first 6 weeks. And then all of a sudden, they started to go downhill. And they started to trigger notification to the physicist. And I'll talk a little bit more about the notification of the physicist on a future slide. So this particular one here was the first notification I received on June 29th. So I analyzed the gamma failure, and I had to put in a conclusion. We call it a physics memo that goes into the gamma report. So I'll just read this to you. It says arcs 1 through 3 were borderline tolerant, and arc 4 was below level on the daily in vivo dosimetry on June 29th due to a change in anatomy. There was fluid in the lungs during CT stim, but none of the images from today. There's also a possible regression of the tumor. The radiation oncologist was alerted by email on June 29th to evaluate for clinical significance. So this was on June 29th. Then on June 30th, of course, I had another gamma failure, so I responded accordingly. This was the memo from my report. That arc 2 was borderline tolerance and arc 4 was below level on the daily in vivo dosimetry on June 30th due to patient weight loss and a change in patient internal anatomy. There's also regression of the tumor. The radiation oncologist has decided to discontinue delivery of the current plan at fraction number 38 and replan with an adaptive boost. These are some images that were taken from Varian offline review, and most of you are probably familiar with that. First, I'd like to talk about weight loss. You can see this particular image on the left, the larger image, is an overlay of the planning image as well as the daily cone beam CT. The images on the right, the upper one is the planning CT, and the one on the bottom is the cone beam CT. So the one on the left is an overlay of those 2 images. And you can clearly see in this region, there's patient weight loss, as well as in the opposite side. It's even more clear on the image on the lower right. You have significant weight loss here and significant weight loss here. You also have a lot of fluid that was in that particular lung. There was even a little bit of fluid in the opposite lung. As you can see on the lower right, that fluid has resolved and is almost non-existent. Finally, tumor regression. That is what we're all mainly concerned about. Not just dose, but we want to make sure we're targeting the tumor. And you can see in this case, there was a significant regression of the tumor on this region right here. And of course, this is just a single slice through the patient's anatomy. So if you were to scroll through each of the slices, you can see varying degrees of these effects of weight loss and tumor regression, as well as the fluid in the lungs. I know this is a busy slide. This just shows the overlay. It's a summation plan that shows the initial SBRT volume, as well as the current treatment volume. The red line, if you can follow that, that is the actual revised PTV for the boost. Now, the maximum dose is going to almost 104 gray. So again, it's very important that we follow this closely to make sure that we don't cause problems in the patient due to tissue necrosis. So for case number 1, in summary, Adaptivo alerted the staff that there were significant changes to the patient's anatomy, including weight loss, tumor regression, and a significant decrease in the fluid within the right lung. Based on the information provided by Adaptivo, the physician discontinued the initial plan early and re-CT'd and replanned the patient's boost. So if we had gone with the original boost without replanning, I have no idea what the gamma results would be, but I'm sure they would not be this good. With the new revised boost, all 12 fractions easily were above threshold and passed gamma. Next, the physician was able to increase the boost daily dose from 2.5 gray up to 3 gray because of the smaller treatment volume. The end result is a significant reduction in the treatment volume, an increase in the tumor dose, as well as a reduction in dose to normal tissue.